All right. Good afternoon, everyone. Welcome to the prep webinar on trauma and psychosis with Dr. Kim Mueser, back by popular demand. If you remember, we had Dr. Mueser here in February for our prep. We're thrilled that he agreed to come back and present another webinar for us. So I'm Jen Sperduto. I'm joined by my colleague Dawn Reinhardt Wood, and we are from the Department of Psychiatric Rehabilitation and Counseling Professions at Rutgers University. And we're also part of the Institute for Inpatient Psychiatric Rehabilitation at Rutgers. So welcome. This is an interactive training, and we encourage you to ask questions and participate throughout the session in the chat box. Dr. Mueser has asked that we hold questions until the end. We'll leave time to address them all, hopefully, but feel free to drop them in the chat, and then Dawn's going to be on the lookout for any comments or questions that come in so that we can get to them at the end of the presentation. At the end of the presentation today, the training evaluation will be available, and they'll have all of today's handouts, training materials, links to the book that Dr. Mueser is going to talk about, and also you can download a certificate of attendance for today. And a recording of this webinar will be available on the IPR website tomorrow, and Dawn will drop that link so that you have the link to our website. Quick disclaimer, the Psychiatric Rehabilitation Educational Program is an online forum for a variety of topics relevant to inpatient psychiatric hospital staff. And while Rutgers and DBHS and DMHAS are co-sponsors of the program, the prep webinars are peer presented, and as such, the content is independently developed by the presenter each month. And the views and opinions expressed in the program are those of the speakers and don't necessarily reflect the views or positions of any entities they represent. So we are being recorded so that we can post the recording of the webinar tomorrow on the website. So just be mindful of that. And I'd like to introduce Dr. Mueser again. But Dr. Mueser is a professor of occupational therapy and psychological and brain sciences, researcher at the Center for Psychiatric Rehabilitation at Boston University, and adjunct professor of psychiatry at the Geisel School of Medicine at Dartmouth. His research interests are on the development and evaluation of psychosocial interventions for persons with serious mental illnesses. His work has spanned a broad range of different interventions, including social skills training, family psychoeducation, supported employment, integrated treatment for co-occurring disorders, CBT for PTSD, illness management and recovery, cognitive remediation, and treatment of first episode psychosis. Dr. Mueser has published over 400 peer-reviewed articles, co-authored over 10 books and 100 book chapters. So we are thrilled to have Dr. Mueser back with us today. And with that, I'll turn it over to you, Dr. Mueser, and you can get started.
Great. Thank you very much, Jen and Dawn, for inviting me. I'm going to start off with my disclosures, which are only that all of my clothes, although unfortunately you can't see very many of them, but my shirt are made by my son, Jay Mueser. He has is a bespoke hand tailor maker of suits and shirts with stores in New York City. So we can go on to the next one. So I'm going to be talking about trauma, and in particular, post-traumatic stress disorder in people with a serious mental illness, in particular, also with psychotic symptoms. So I want to begin with a definition of trauma according to the DSM-5, which is an event that involves some direct threat of death, bodily harm, or psychological injury to the self or another person. Go on to the next one. So common traumatic events include rape or sexual abuse or assault, combat, accidents, being a victim of crime or assault, natural disasters, it could be man-made disasters as well, the sudden unexpected death of a loved one. And then there are some traumatic events that are specifically related to psychosis. I'm not going to be spending a lot of time on these, but the basic principles of treating trauma-related reactions or post-traumatic stress disorder also appear to apply to traumatic events related to psychosis. So that could include things such as psychotic symptoms, which can be terrifying when experienced, like hallucinations or delusions, involuntary treatment, such as a hospitalization or being put in seclusion or restraints, or being threatened in an inpatient setting. Next one. So, what is the importance of trauma in people with psychosis? First, we know that there are higher rates of trauma in people with psychosis. And one of the reasons for this is that traumatic experiences during childhood and adolescence increase the chances of somebody developing a psychosis. And then we know that after somebody has developed a psychosis, they're also at increased risk for re traumatization for a variety of reasons, places where they live, high rates of substance use problems, and so on. We also know that multiple traumatization is possible in people with serious mental illness, and that a history of trauma is associated with more severe psychiatric symptoms and greater levels of distress. We also know that service users report that traumatic experiences are important but are often neglected in treatment. Next slide. This is just data from one study. It was conducted at 2 inpatient settings and 2 outpatient settings, one in relatively rural New Hampshire and the other in Maryland. And what you can see is what's charted in red are the rates of trauma in childhood, and in green are in adulthood. And so you can see the rates of sexual assault or abuse in women were about 50% in childhood, even a little bit higher in adulthood. For men, it was around 30 to 35% in childhood and a little bit lower in adulthood. You can see pretty high rates of physical assault, both in childhood and in adulthood, as well as witnessing a death and assault. And these are just a few selected traumatic events. So they really illustrate the high rates of trauma, both in childhood as well as adulthood in people with serious mental illness. Next slide. So I'm going to be focusing a fair amount on post-traumatic stress disorder. And so what I want to do first is briefly review the symptoms of PTSD, and then also provide a rationale for focusing on PTSD. First of all, the diagnosis of PTSD requires exposure to a traumatic event, as briefly described earlier. There are also criteria for inclusion of at least some symptoms in each of the following 4 clusters of symptoms. There are intrusion symptoms. The most common intrusion symptoms are intrusive memories, a memory popping into a person's mind when unexpected, or it could be cued by something. There could also be flashbacks where people feel as though the traumatic event is happening again, or nightmares. Avoidance of trauma-related stimuli is the second cluster of symptoms, and that can include avoiding memories or situations related to the trauma. It could also include not being able to remember certain aspects of the traumatic event. The third cluster are over-arousal symptoms, such as hypervigilance, difficulty sleeping, anger outbursts, an exaggerated startle response. And the fourth one is negative alterations in cognition and mood. And that can include the inability to remember parts of the event. It used to be in the avoidance trauma-related stimuli. It got moved to this cluster, so pardon my mistake. Persistent negative feelings, detachment from others, blame for the events, and so on. Pervasive fear, what might be another example. And here are some other, no, that's great. I appreciate your going on when I finish the slide. And there are a number of other very common symptoms or problems related to PTSD. We know rates of suicidality and self-injurious behavior are very high. Often self-injurious behavior, when it's not suicidal, may actually be an attempt to distract or escape upsetting memories of the events. And so that kind of provides an understanding of sometimes of the purpose of those behaviors. Substance use behaviors or disorders are very common, especially, for example, alcohol, which people may use to attempt to regulate sleep because of the persistent over-arousal. There's a literature showing that people with severe PTSD are more likely to actually have hallucinations and delusions that can't be explained by another axis 1 disorder, such as schizophrenia or psychotic depression or bipolar disorder. And there's quite a bit of research showing this now, and it occurs cross-culturally. So, for example, in Japan, hearing the voices of a loved one who has passed are not uncommon at all in people who have PTSD following the sudden unexpected death of a loved one. Interpersonal difficulties are very common, in part because a lot of the trauma experience is interpersonal in nature, which can lead to pervasive feelings of distrust in other people, and difficulties in employment or work functioning, as well as functioning at school, are problems often related to PTSD. Next. So why focus on PTSD? And I say this because, of course, we know that trauma has a broad range of different consequences on people's lives. And many of these consequences may be individual and vary from one person to another. So why focus on PTSD instead of a broader range of more individual responses that people have? And here are the reasons. First of all, we know more about PTSD as an established consequence of trauma than about any other particular syndrome. And we know there's a high prevalence of PTSD in people with a psychosis. In fact, in one meta-analysis, the prevalence of PTSD in people with psychosis in 29 to 33 studies was about 30%, 30 to 33%. So that's pretty high. And these are rates of current PTSD in people with a psychotic disorder. And in fact, the rates are even higher in people with severe and persistent mood disorders, such as major depression. At the same time, PTSD is very often undetected in people with psychosis. In many studies, the rate of PTSD being indicated in somebody's charts is under 5% of the people who had PTSD. We also know PTSD is associated with very high levels of distress and use of acute care services. Assessment methods, which I will go through, are pretty straightforward for assessing PTSD. Psychological treatments are effective, both in the general population and among people with a PTSD, and I'm sorry, among people with a serious mental illness. And PTSD also worsens the course of the illness. So if we can effectively treat PTSD, not only can we reduce the significant suffering associated with it, but we may well improve the overall course of the illness. Next slide. I'm not going to go into this in a lot of detail here, but this is a model that we developed over 20 years ago that is based on a lot of evidence supporting it. And what it basically argues is that having PTSD in a person with a serious mental illness, a psychosis, for example, having PTSD increases the chances of symptom relapses and the severity of symptoms, both in indirect ways, such as through increasing substance use or interfering with a working alliance or leading to re-traumatization, as well as direct ways. So, for example, PTSD leads to the avoidance of trauma-related stimuli, which can lead to the avoidance of developing close connections with other people, resulting in lower levels of social support. Or PTSD can lead to the over-arousal symptoms. And we know high levels of arousal in and of themselves can predispose people to relapses and rehospitalizations. So this is a complex model arguing that if we can improve PTSD symptoms, we can improve the course of psychotic disorders and other disorders. So now I want to spend a little bit of time distinguishing psychotic symptoms from PTSD symptoms, as well as pointing out instances in which a psychotic symptom may also be a PTSD symptom. And what I'll be talking about will be specifically the psychotic symptoms of hallucinations and delusions. I'm then going to talk about negative symptoms, distinguishing negative symptoms from certain avoidance symptoms in PTSD. And then I'm then going to talk briefly about manic or hypomanic symptoms and distinguishing them from some of the symptoms of PTSD. So let's go to the next slide. So the first question is, how can you distinguish hallucinations from intrusive memories in PTSD? Remember, intrusive memories are typically when the memory of an event pops into a person's mind, often when they least expect it. So that's what an intrusive memory is. A hallucination, on the other hand, is a sensory perception of the external world. It's usually visual or auditory, of stimuli that are not present. Now, hallucinations can also be internal, such as hearing voices inside one's head. but they're nevertheless experienced as sensory perceptions. And that's distinct from an intrusive memory, which is a specific memory. It's kind of like a picture. It can even include sounds in one's mind, but they are not confused with external stimuli or internal stimuli produced by the brain. So hallucinations can also be intrusive memories if they're clearly related to the traumatic event. So, for example, I've worked with soldiers. I worked with a wounded soldier, a soldier who had been wounded during combat, who heard auditory hallucinations of comrades calling to him. And this is an experience that he had actually had, but then he had hallucinations that were actually related to it. And so it would be considered both a hallucination and an intrusive memory. If hallucinations are not clearly related to the trauma, then they're just hallucinations. Now, of course, they can be hallucinations that are related to PTSD, but we wouldn't call them intrusive memories or a symptom of PTSD according to the DSM-5. If intrusive memories of trauma are only experienced in the person's mind, but are not perceived in the outside world or experienced as sensory stimuli, then they're just intrusive memories. Let's go on to the next one. This one concerns hallucinations versus flashbacks in PTSD. Now, let me say to begin with, a lot of people, not clinicians so much, but clients, confuse intrusive memories from flashbacks because they kind of seem similar. But the primary difference is that in a flashback, a person is having a momentary re-experiencing of the traumatic event itself. They're actually transported back in time to the event. It's kind of a dissociative a symptom. It's usually brief, and there's actually a loss of touch with current reality, where they are, date, the safety of the situation, and so on. So flashbacks are a dissociative symptom and are much less common than intrusive memories. Intrusive memories, in my experience, occur in almost everybody with PTSD. But flashbacks, I would say they occur genuinely in maybe 10 or 15% of the individuals. Hallucinations, of course, as described, are sensory perceptions, usually visual or auditory, of the external world that are not present in that world. But there is no loss of the person's current set, so to speak. In other words, they are oriented towards date, time, location, where they are, in contrast to a flashback when they momentarily, in effect, go back in time as though the experience is happening again. So hallucinations don't have a loss of contact with reality, such as it is in terms of orientation, whereas flashbacks temporarily do. If a flashback is confirmed, if the person actually has this loss of set in terms of where they are, then it wouldn't be considered a hallucination. It would be considered a flashback. And if a hallucination is related to a traumatic event, but doesn't involve the loss of contact with current reality, then it would be considered an intrusive memory, but not a flashback. So the key distinction is the loss of orientation to where the person is and the current circumstances of their current situation. Next one. So let's talk about delusions versus valid memories of traumatic events. Memories of traumatic events in people with serious mental illness, including a psychosis, are often valid, in fact, usually valid, but it is possible that for people to have delusional memories of traumatic events that actually did not occur, in which case they should not be treated for PTSD. And I'll talk a little bit about why this is the case. And you could also have delusional elaborations of actual events that occurred, and these should be treated. So how do we distinguish when a delusion, when a reported traumatic event is delusional versus when the event may be real and there may be a delusional elaboration on the event? So and there's no real easy way of doing it, but it's kind of a bit of detective work. And so the characteristics of traumatic events that are delusional tend to be very extreme reports of severe trauma with multiple perpetrators, reports of bizarre traumatic experiences, things such as satanic ritual child abuse, alien abductions, the lack of verification of severe abuse, or where reports are clearly contradicted by other believable evidence. And then there's a last one, which is kind of interesting, which is that sometimes there are clients, and of course, you can develop delusional beliefs about traumatic events. It can occur under hypnosis. It can occur just based on beliefs and expectations. But sometimes when people have these experiences, they're driven by high motivation to uncover more types of events. And the uncovering of more events can both increase distress, but it can be motivating to people because they feel they're getting to the bottom of it. But at the same time, we know in terms of the symptoms of PTSD that one of the core symptoms is avoidance of trauma-related stimuli. So whenever you're working with somebody who reports about traumatic events and appears to have a strong motivation to pursue and uncover and talk more about those events, that should be a warning sign because it's really contradictory to the symptoms of PTSD. And the basic traumatic events may, in fact, be delusional. Now, some individuals have experienced traumatic events like childhood physical abuse, neglect, which form the basis for a delusional elaboration. So, for example, we treated one client in one of our studies who had a great deal of abuse and neglect in childhood, and she had she had reports of those kind of events, but she also had a delusional traumatic experience of being forced by drug lords to fly a helicopter at gunpoint. So this is clearly a delusional elaboration, but all sorts of investigation more or less confirmed, and in terms of the consistency of reports, that she had in fact experienced significant abuse and neglect for her parents. And in these situations, the PTSD, in fact, can be treated. And what you do in treatment is to focus primarily and initially on those parts of the traumatic events that are most plausible and that you have the greatest confidence in that actually occurred. When people have delusional reports of traumatic events where your consideration is that they probably didn't exist, the preferred thing to do is to steer the focus off of trauma work proper and to focus more on other kinds of concerns and issues that the individual may have. Direct trauma work on individual with delusional beliefs sometimes leads to an increase in the number of delusional beliefs and an increase in associated distress, somewhat paradoxically. The next one. Negative symptoms versus avoidance of trauma-related stimuli. So common negative symptoms in people with psychotic disorders include apathy, or the lack of motivation, reduced effort to pursue goals, and avolition, difficulty initiating and sustaining behaviors necessary for improving functioning. Avoidance of trauma-related stimuli in PTSD, on the other hand, refers to active efforts to avoid distressing situations, thoughts, and feelings, etc., that remind the person of the traumatic event. So on the surface, it may be that apathy and avolition appear to overlap or to be similar to avoidance. But the primary distinction is that because both of them are resulting in social withdrawal, reduced engagement in work, school, and the like. But the distinction lies in the role of anxiety in the avoidance symptoms versus negative symptoms. It's certainly true that people with negative symptoms can have anxiety. Absolutely. They often have anticipation of social rejection and things like that. But the avoidance tends not to be driven by anxiety, but rather by reduced drive and motivation in people with negative symptoms. On the other hand, the avoidance symptoms in PTSD are primarily driven by a desire to avoid the anxiety associated with situations. So a matter of additional exploration can often uncover whether a person's lack of engagement is actually an active avoidance strategy versus a negative symptom reflecting reduced levels of motivation. When you have objective measures of PTSD, by the way, and of negative symptoms, they tend not to be correlated. The correlation is close to zero between the two of them. So they are possible to distinguish from one another. And it may be possible to have both at the same time, but pursuing and understanding the role of anxiety can provide information in terms of whether it is more likely to be an avoidance symptom versus a negative symptom. Next one. So now manic symptoms versus overarousal symptoms in PTSD. So in mania, this can be an important one for reasons I'll get into in the next slide. In mania, decreased need for sleep is a characteristic, a symptom. One of the number of symptoms that is frequently diagnostic of or suggestive of the presence of a manic episode. But it's possible, if you don't do the adequate questioning, it's possible to mistake decreased need for sleep with difficulty sleeping in PTSD, which is an overarousal symptom. So the key distinction is the person's affective stance regarding the sleep disturbance. When somebody has mania, there's a reduced need for sleep, and they will report feeling perfectly rested after only 2 or 3 hours of sleep. They're just full of energy, 20, 21 hours a day. In contrast, people with PTSD who have difficulty sleeping and often stay awake, sometimes not falling asleep till very early in the morning, often want to go to sleep. They're very distressed by not being able to sleep. When they get up, they feel groggy, tired, and distressed. And so they may appear to overlap with one another, but it only takes a little bit of investigation to just see how rested the person feels the next day. In mania, they get up after they are completely refreshed after only a few hours of sleep, in contrast to PTSD. Now let's talk about anger outbursts in PTSD with the overlap in irritability and mania. For this particular symptom, there is a genuine overlap. There's no amount of questioning that can distinguish anger outbursts from irritability because they clearly can both happen together. So when is anger outbursts or irritability, when are they a symptom of PTSD and when are they a symptom of mania? And the idea here is to look at the broad set of symptoms that the individual has. And if the individual has a whole lot of other manic symptoms present, such as pressured speech, relentless pursuit of ideas that get them into a lot of trouble, reduced need for sleep, and so on. And then they also have irritability or anger outbursts. Well, then it can probably be best interpreted as a symptom of mania. And if, in contrast, the person doesn't have very many manic symptoms, but they've got the disturbance in sleep in terms of not being able to get to sleep, they've got the hypervigilance, they've got the avoidance of trauma-related stimuli, intrusive memories, persistent negative affect, and things like that, then the outbursts or irritability are more readily explained by a PTSD. Last, it tends to be that PTSD co-varies. In other words, the presence and the severity of PTSD fluctuates over time. And the worse a person's mood is, in particular, like in terms of depression, but depression and anxiety, the more likely they are to have PTSD. So people tend not to have PTSD right at the, or they don't tend to have it as severe right at the height of a manic episode. They're much more likely to have it during a depressive episode. So being able to distinguish PTSD from manic symptoms can be important. Go on to the next slide. So to talk a little bit about misdiagnosis of PTSD as a serious mental illness. So hallucinations, delusions, and bizarre behavior can all occur in severe PTSD in the absence of other disorders. And this can lead to a misdiagnosis of schizophrenia when PTSD is the proper diagnosis. I've seen such cases, I've picked them up, I've treated them. I don't think this is a very common occurrence, but it's common enough probably to warrant attention. Clients with PTSD symptoms tend to avoid talking about their traumatic events. And so if they're not asked by clinicians or about their symptoms, they may readily be attributed to another disorder. And so what this means is that it's important to systematically screen all clients with serious mental illness for PTSD. If a person has lots of PTSD symptoms, but few schizophrenia symptoms, like negative symptoms, significantly impaired functioning, they might only have PTSD, and their psychotic symptoms might improve with treatment. If the person has many PTSD symptoms and schizophrenia symptoms, then they may well have both disorders. And as we discussed earlier, in a big meta-analysis indicated about 30% of people with psychotic disorders also had PTSD. Next slide. So now I want to talk a little bit about the misdiagnosis of PTSD as a serious mental illness. And some of this may come to news to you, but that has to do with the fact that sometimes the treatments for major depression can create symptoms that end up mimicking PTSD and are mistaken as symptoms of bipolar disorder. And here's how that works. We know that major depression is the most common comorbid disorder with PTSD. In the general population, we know that about 50% of people with PTSD also have major depression. And we know among people with a severe mental illness, among those with major depression, about half of them have a PTSD. So people with PTSD often seek treatment for depression without revealing their trauma history. Because remember, they're avoiding trauma-related stimuli. So they're depressed, they're seeking treatment for depression, but they're not talking about their traumatic experiences. And so a common response is to prescribe them antidepressant medications. Now, the thing about antidepressant medications is that they can precipitate mania, both in individuals with bipolar disorder, but also in individuals who don't have a history of bipolar disorder. And this phenomenon has been called the switch process. It's been known since at least the early 1970s. And an antidepressant medication taken over a long enough period of time by somebody with this vulnerability can precipitate complete manic episodes that are indistinguishable from the mania that you see in bipolar disorder. But it's something that can't be diagnosed as a bipolar disorder ordinarily if it's precipitated by antidepressants. But what happens is that if it precipitates a manic episode and the person is taken in, they're taken off of the antidepressant medication and they're monitored, and they appear to still have some bipolar symptoms, like they appear to have difficulty sleeping, they appear to have irritability, and so on. Unless a trauma history is taken, those symptoms can be misdiagnosed as persistent symptoms of bipolar disorder. And this can lead to the person then, over time, eventually being diagnosed with bipolar disorder, given a mood stabilizer and the like, and treated with bipolar disorder. And I've met people who've been treated for over 20 years based on a single episode of mania that was triggered by an antidepressant medication, when in fact their proper diagnosis was PTSD. So the idea here is that the symptoms of sleep disturbance can be confused with decreased need for sleep. And the symptoms of irritability can be, are actually overlap, of course, with the irritability that is seen in a manic episode of bipolar disorder, leading to a misdiagnosis of bipolar disorder when a proper trauma history and assessment of PTSD would lead to the diagnosis of PTSD. So I know I went through that a little bit fast, but you'll be able to see the slide. By the way, over a 2-year period of time, for people on antidepressant medications, the risk of developing manic or hypomanic symptoms is around 10%. This was shown in a meta-analysis conducted about 5 years ago. So that's a pretty significant risk factor. So this is something useful to know both clinically as well as personally, because I've picked this up 3 times with different people that I've known or friends and things like that. So it's probably more common than people think. Okay, let's move on. Next slide. Thank you. So I'm going to quickly go through. Oh, now we previous slide. Previous. Okay, that's it. So I'm going to briefly go through the assessment of PTSD. We have effective instruments for screening PTSD. We've used them at this point literally with thousands. Sorry, it's we're going to losing a little. To that, yeah, thank you. We've literally used these with. Are you having some problems with the?
Dr.
I
Mueser, which slide did you want? This one?
No, I wanted the previous one.
This is the
That
previous
one.
one.
Yeah,
Okay.
yeah, just thank.
Sure. Sorry
Um,
about that.
those okay. It takes about 15 minutes to, you see, it keeps moving. It just moved to the previous one before that now.
It's not moving on my end, so
Is
I'm
it?
this is very strange. You want this one, the assessment of trauma and PTSD.
Yeah, but that's not on my screen. What's on my screen is misdiagnosis of PTSD as SMI.
That's very strange.
I'm seeing assessment of trauma and PTSD, but it did change like a little glitchy a couple times. Yeah.
Right. Well, I'm seeing it now also. So
Okay, there may be some delay then. Yeah.
Okay.
Sarahi, I
Well, we're
see
gonna keep it
Sarahi.
there.
There's a delay. All right, we're
All
good.
right. Because I'm like,
okay.
I don't know what you're talking about. Okay.
So it takes about 15 minutes to screen. The important thing to bear in mind, in my opinion, is that there is no typical person with a severe mental illness or psychosis and PTSD. In other words, you can't count on your clinical acumen to pick it up. And I say this as somebody with a fair amount of expertise in both. I'm a little bit embarrassed to say that there are times when I've worked with clients literally for months who had PTSD, and I knew how to assess it, and I hadn't routinely assessed it, and in fact, I eventually learned that they had it, and it really had a radical effect on changing my treatment, a course of treatment with them. So the important thing is that you accept that there's no typical person with PTSD, and that PTSD symptoms can masquerade as other symptoms. It's important to just do a routine trauma screen with all the people that you work with. The best way to administer these trauma screens is through brief interviews. They can also be done through reports. You don't need to do a lot of preparation of the client for this, but it is useful to say something like you're going to ask some questions about difficult experiences that they may have had in the past. You want to be matter of fact, use behaviorally specific language, and avoid using loaded words like abuse or rape. Let's go on to the next one. Great. So what we do is we have a two-part assessment. The first part that we have often used has been an abbreviated version of the stressful events screening questionnaire. It's got 16 questions. We have a revised version of this in the book that we recently published as well. And it simply asks whether or not a person has had one of these traumatic experiences in their lifetime. Next. And then we administer the PTSD checklist, the PCL-5, which is a 20-item self-report scale for screening PTSD. And the items correspond to the DSM-5 symptoms of PTSD. And the client rates how much they've been bothered by the symptom over the past month. Total score PCL scores of over 33 or over indicate probable PTSD. And it has very good reliability with structured interviews for PTSD. It's been used in many people with serious mental illness and other populations. You can also use the PCL-5 to monitor the effects of treatment over time. Go on to the next one. So I'm not going to go into this in much detail because I want to jump ahead and get into the rudiments of our cognitive restructuring program for PTSD. Let me just say briefly that the strongest evidence for treatments of PTSD in the general population is exposure-based approaches that include imaginal exposure, where people talk about the traumatic events themselves, as well as in vivo exposure to feared situations, and CBT or cognitive restructuring approaches, where you help people identify and change trauma-related thoughts and beliefs they have about themselves and the world. And we've developed, both these approaches are equally effective. Combining the two is not more effective. So for practical reasons, we have developed a program focused specifically on cognitive restructuring in people with psychosis for a couple of reasons. First, we believe that such programs will be more acceptable to people with serious mental illness because a lot of people are afraid of direct exposure to trauma-related stimuli. Second of all, we know a lot about how to do CBT or cognitive restructuring in people with a psychosis, and we have somewhat less experience in terms of doing exposure. There's now growing evidence that you can use exposure, but probably not as many people want to participate in it. So for those reasons, I'm going to go into describing our cognitive restructuring program for people with a psychosis. So next slide. And we can skip this slide because I've more or less covered it. And you can skip this slide. And you can skip this slide.
Wow, you really are on a delay.
Yes.
It's taking a while for those to pop up for you.
Yeah, it's like 2 or 3 seconds. This is just the cover of our book that just came out in December of last year, which contains everything that I'm saying here and much more, plus lots of useful resources. There's kind of a tour of the book at the end of this slideshow, which I will not be going through here. Let's go on to the next one. So this is the program is typically a 12 to 16 week standardized CBT intervention. The sessions are delivered on a weekly basis. It can be provided anywhere. And in fact, the first experiences we had with the program were actually providing it on an inpatient setting at New Hampshire Hospital. And there are 8 therapy modules of the basic program. Let's go on to the next slide. I'm going to skip this one. This is simply a slide saying we do monitor PTSD symptoms throughout the program, and we incorporate the results of that monitoring into the treatment sessions. Go to the next slide. So the organization of the program, it begins with an overview of the program. We then help people come up with a distress response plan. We then teach breathing retraining as a way of reducing arousal and as a coping mechanism for anxiety. We then provide psychoeducation about the nature of trauma and the nature of post-traumatic stress disorder, aimed at helping people understand PTSD symptoms that they're experiencing, as well as the fact that these are common reactions to trauma that that other people have. This reduces a sense of aloneness and things like that. And that it's something that is, because it's a common reaction, it's not people's fault. We then introduce cognitive restructuring, and I'll give you a little bit of a sense of the 2 different modules in which we introduce it. And then what we do is we work on generalizing the ability of people to use cognitive restructuring as a skill, even after the intervention is over. I should say that the first 5 modules up to psychoeducation 2, we do those over 3 sessions. And while I'm not going to be talking about it here, we have a standardized brief intervention for PTSD, which we've shown significantly improves PTSD symptoms. And there's more information about this in the book, as well as in the online appendix for the book. There's even a treatment manual for this brief intervention that we call BREATHE, BREATHE, which has been shown, much to our surprise, to reduce PTSD symptoms. Let's go on to the next one. So I'm going to zip through these modules up to the cognitive restructuring to give you a flavor specifically for the cognitive restructuring. So if you could just keep going forward, this is the overview, the distress response, breathing retraining, and then psychoeducation. I kind of covered this where we talk about that. And then here is the first of 2 modules on cognitive restructuring. We usually spend 2 to 3 sessions on this. We introduce how thinking is related to feelings and are related to behavior, the cognition, emotion, behavior, a triad. in order to establish that not all thoughts and beliefs in a particular situation are equally accurate, and that sometimes traumatic experiences and other life experiences can lead to inaccurate thoughts and high levels of distress. And that when you examine thoughts that you have, when you're feeling distressed, sometimes if you follow particular strategies, you can identify them as being inaccurate and you can correct them, and that can reduce the negative feelings. So we introduce a basic skill of cognitive restructuring as a way of dealing with negative feelings. And many of you may be familiar with the concept of cognitive distortions, as written about by David Byrne. And we use you can go on to the next one. We use the same concept of cognitive distortions, but we call them common styles of inaccurate thinking. So this is like all or nothing thinking, thinking that you're either the best mother in the world or you're a terrible mother, catastrophizing when you think that the very worst thing is always going to happen versus there are many other possibilities, forecasting, predicting the future, mind reading when you think you know what other people are thinking. And so after introducing the thought, feeling, behavior triad and the notion that not all thoughts are equally accurate, we teach people about these common styles of inaccurate thinking. And the idea is that if you're having an upsetting feeling, examine the thought related to that upsetting feeling and see if it's one of these common styles of inaccurate thinking. And then if it's not accurate, come up with a more accurate thought for that situation. And that often reduces negative feelings. And so this is the first cognitive restructuring skill that we teach. And we teach it because a lot of people can grasp these common styles of inaccurate thinking and begin to use the skill even from the beginning. So we spend 1 to 3 sessions teaching the common styles of thinking before we then move on to the second cognitive restructuring skill, which builds on this. And we can go on. So the second cognitive restructuring skill is what we call the 5 steps of cognitive restructuring. And as I say, it builds on the common styles of thinking in the following way. Step number 1 is describe the situation. Step number 2 is identify the strongest emotion. Step number 3 is identify the strongest thought or belief that's related to that emotion. This is where you get often to eventually to trauma-related thoughts and beliefs, what the traumatic event has meant to the person as they've kind of internalized it and believed it. Then what you do is you evaluate the thought. And here's where we prompt people to ask, is this a common style of thinking? We also teach people lots of other strategies for evaluating thoughts, whether they're accurate or not, such as focus on objectivity and could you convince another person that this is true and so on. And then the last step is what we call the take action step. And you either change the thought if the evidence doesn't support the thought, or you develop an action plan to deal with the situation if the evidence does support the thought, or it's possible to do both. And I'm going to kind of walk you through a kind of a simplified example of the 5 steps of cognitive restructuring as explained to a situation of PTSD related to childhood sexual abuse. So next slide. We can skip this. This is the worksheet, but I'm going to walk you through an actual completed worksheet. You can see the 5 steps there. Okay, so here it is. Describe the upsetting situation, thinking about my uncle sexually abusing me. So it's kind of like the upsetting situation here is having an intrusive memory of the event. And identify your strongest feelings. And in this case, the person identified guilt and shame. By the way, guilt and shame is quite common as the most upsetting feeling in childhood sexual abuse, in at least some instances of it, because often behaviors are repeated over a period of time, and there's a certain level of adjustment, and sometimes the victim actually blames themselves for it, or blames themselves either for having sexual responses, or not for telling other people, or things like that. Let's go on to the next one. So here, identify your thoughts. Here, what we try to do is to get people to identify several different thoughts related to the situation, and then to pick the most upsetting thought. And this is where we go a little bit beyond just the common styles of thinking. So one thought is the sexual abuse was my fault. A second thought is there's something wrong with me because I let it happen. A third thought is, I'm a bad person because I was sexually abused. And then we say, okay, well, what was the most upsetting thought? And here the person says, number one, the sexual abuse was my fault. And then we say, okay, is this a common style of thinking? It's not always a common style, or they might not be able to identify it. But in this case, the person wonders, is it emotional reasoning? In other words, do I feel bad because I feel bad about myself? Does that make me think that the sexual abuse was my fault? Emotional reasoning is when a person has a feeling and then they come up with a thought that is based on that feeling. It's a little bit backwards from most of the other common styles of thinking. So let's go on to the next one. So here's where first we challenge your thought. So so the first thing is, what are the things that do support my thought? And then the next one is the things that don't support it. But the things that do support it, well, my uncle told me I was special. I never told him not to touch me. I could have stopped it. When I finally told someone about it after several years, he did stop, and I hardly saw him again. Sometimes he was nice to me, and I must have wanted it. Now, notice, not all of this is very good evidence, but we don't do a lot of questioning of the evidence up front. First, we generate a big load of evidence for and against, and then we help the person evaluate it, and we say, hey, focus on the evidence that's strongest. That way you don't get into a debate about every piece of evidence. So this is all the evidence for it. Now let's go to the next slide. And here's all the evidence against it. I didn't like my uncle touching me and making me do sexual things. He threatened me not to tell anyone. I was afraid to tell anyone. And I was a child. I didn't know what to do. Let's go on to the next one. So now this is the take action. So you ask yourself, does the evidence mostly support my thought, or does it mostly not support my thought? And here the person said, no, my thought is not supported by the evidence. We can go on to the next one. And now here's take action. So what's the new thought? Instead of I was to blame, I was a child and afraid. It wasn't my fault that my uncle abused me. So let's go on to the next one. I know I got a little bit of time for questions. So an action plan, you do an action plan when a person has an upset feeling about something. And then when you examine the situation, they've got a good reason to be upset. So you don't want to change your thinking when a person is in some kind of danger or has a realistic concern. What you want to do is to help them develop an action plan for dealing with a situation. And an action plan is just like a mini problem solving. You define the goal, you brainstorm possible strategies, you plan how to put a strategy into practice, and then you set a time to follow up on the plan, the time or situation. Let's go on to the next slide. So here are a number of common situations that call for action plans. As I say, an action plan is called for when there's a new realistic concern. So let's say a person is developing a health problem, or let's say there's early signs of abuse in a new relationship. These action plans are very helpful because people with PTSD tend to have an avoidant coping style, and so they avoid warning signals when they come up of possible danger. And so having an action plan often helps people attend to those early warning signs. It can also be useful in identifying and implementing coping strategies for PTSD symptoms. Like, let's say somebody comes into session and they've had a terrible night's sleep, and they've got these thoughts in terms of my life is never going to be good. I'm never going to get a good night's sleep, and so on. And so you do a cognitive restructuring, and you help the person see that they're forecasting, they're jumping to conclusions. It's black and white thinking, maybe, and maybe it's not completely accurate. And a more accurate thought might be, well, I didn't get a good night's sleep again last night, which is really distressing because it makes me really tired and I don't get as much out of my day. So it's a more realistic thought. It's associated with a little bit less upset, but it's still a problem situation. The person is upset and not getting a good enough night's sleep, and they have a realistic thought about it. So then what you can do is you can come up with an action plan aimed at developing strategies for trying to improve the person's sleep. So it might include sleep hygiene things like setting regular time to try to go to sleep, developing a relaxing routine. Could involve exercise for fatiguing the person and so on. But there would be an example of where an action plan is used to develop coping strategies for persistent PTSD symptoms. So I think what I'm going to do is if we go on to I'm going to put one slide up. Let's just go a few slides forward. Let's go to the next one. Okay, why don't we go to the slide before this one? Yeah. This one's fine to have. I have pictures in the slides that you can look at that show the results of two large randomized controlled trials evaluating our CBT, or our cognitive restructuring program. The first trial compared it to treatment as usual, and you'll see there are slides that show both the CBT intervention, the cognitive restructuring intervention, improving people's PTSD symptoms and their depressive symptoms much, much more than treatment as usual. And then the next study, you'll also see two more slides, also showing reduction in PTSD symptoms and in depression when in a study where we compared the cognitive restructuring program with the brief program, just the first 3 sessions. And in that study, well, why don't you go a little bit more forward? 2 slides. Yeah, stop there. Go one back. So here you can see the cognitive restructuring program was still more effective than the brief program, but the brief program was a lot more effective than treatment as usual in the previous study. But in any case, both of these randomized controlled trials show that the cognitive restructuring program was more effective than either treatment as usual or a brief intervention. And interestingly, the brief intervention did appear to be much more effective than treatment as usual. So it gives evidence for the effectiveness of the overall cognitive restructuring program, but also suggests that the brief program may produce beneficial effects. You'll be able to see these slides on your own. So at this point, why don't I just open it up for a few questions? Sorry for going a little bit over, but I'm happy to take any questions that people have.
Hi, Dr. Mueser. So I took down some of the questions that were in the
Great.
chat here. I'm going to go through a couple of them. From Joy, Joy asks, how do we address the traumatic experiences for someone with delusions without increasing the delusions? So how do we work around, addressing those while not increasing?
I'm going to assume for the moment that that we're talking about somebody with delusions, but not necessarily delusions about the traumatic event. That's the most common thing. It's common for people to have delusions, but not necessarily about the traumatic event. And it's possible to do education and kind of normalization about the symptoms of PTSD, symptoms that people with a psychosis may have, and can then attribute or understand how their life experiences led to that, without actually increasing the severity of the psychotic symptoms. In some ways, providing a way of understanding these post-traumatic reactions can reduce the stress that people have and help them realize that some of these reactions that they had to the traumatic event are in fact very common and shared by other people, which can actually reduce the distress associated with those symptoms.
Thank you. I would think that would be very helpful and distress reducing for individuals,
Yes.
which would obviously probably help their other psychiatric symptoms. So thank you.
Yes.
Another question posed from Dr. Stevens is, I'm a 70% disabled veteran with PTSD. I am a trauma chaplain, and I work at Ancora Psychiatric Hospital, which is one of our state
Wonderful.
hospitals, as you know. I was a corrections officer for 5 years also. Does my PTSD, perhaps, and I think this is probably relative to a lot of people in the field, does my PTSD drive me to careers that may cause PTSD?
There is one could even become Freudian about this, because there's this concept of how people go back to traumatic experiences in order to try to master them. I wouldn't say that that the PTSD is driving you to a profession that is causing PTSD, but there may be, when people have a challenging life experience, there's something within them that often causes them ironically or paradoxically, to keep going back in order to try to get it right, in a way. And so there may be a very, very healthy aspect, of this, which you're trying to kind of master a previous, a challenging experience, and it sounds like you're trying to master it by helping other people, with similar experiences, and your lived experience of it may well, be part of how you can help.
Kind of that helper healer principle, right?
Yeah, yeah.
So thank you so much. And as I noted, we had quite a few questions, but we're going to go ahead and table those other questions because of time constraints, and many of them were answered in your presentation. So I appreciate that. Let me see.
Thank you for having me.
That
I really appreciate it, and everybody, thank you for your interest. You can find me on email if you have questions, but I think many of them you'll also find somewhere in the book.
Right, and
And we
remember
wanna-
all of the training, all of the slides are available from the training evaluation that you can download and have all of this information and get your certificate and the link to the book if you're interested in checking that out. And anything else, Dawn?
I think that's it.
Dr. Mueser, thank you so much for being back with us today, and thank you all for joining us, and we will see you next month on June 17th for the next prep. Take care, everybody. Have a great day.
Thank you all. Take care.
Bye.
Mm, 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 mm.